If you've been with us since our last video, you already know that mechanical ventilation has two primary goals: ensure viable gas exchange and decrease the work of breathing. You also know that CO2 elimination is controlled by minute ventilation, and minute ventilation is controlled directly by tidal volume and respiratory rate. But knowing what they are and knowing how to use them are two completely different things. Today, we are going deep. We're talking about what tidal volume and respiratory rate actually mean at the bedside, how to set them correctly for your patient, not just by the book, how they interact with each other to control CO2, and, most critically, what happens when you get them wrong. Because the consequences are not abstract. They are real, they are documented, and they are preventable. Let's get into it. Let's start with tidal volume. Abbreviated TV, or V.T, tidal volume is simply the amount of air delivered with each individual breath, measured in milliliters. When you breathe normally at rest, your tidal volume is roughly 400 to 600 milliliters. That is about the size of a standard water bottle. Nothing dramatic, just enough air to keep your alveoli open and your gas exchange running smoothly. On a ventilator, we set the tidal volume deliberately, and the number we choose matters enormously, because unlike natural breathing, the ventilator will deliver that exact volume breath after breath, hour after hour, whether the lungs can handle it or not. Too little tidal volume and the alveoli collapse, a process called atelectasis. Too much tidal volume and you overstretch and damage the lung tissue itself, a condition called volutrauma. Either way, the patient loses. So what is the right number? That brings us to one of the most important pieces of evidence in all of critical care. The evidence-based target for tidal volume in mechanically ventilated patients is 6 milliliters per kilogram of ideal body weight, written as 6 milliliters per kilogram IBW. This comes directly from the landmark ARDS-NET trial published in the New England Journal of Medicine in 2000, which showed that using lower tidal volumes, 6 milliliters per kilogram IBW, compared to the traditional 12 milliliters per kilogram, reduced mortality in ARDS patients by 22%. That is one of the most significant findings in the history of critical care medicine, and it changed how every RT and intensivist approaches the ventilator. But here is what trips up a lot of students and new grads. We use ideal body weight, not actual body weight. Why? Because lung size correlates with height and sex, not with how much a person weighs. A 300-pound patient and a 150-pound patient of the same height have roughly the same lung size. Giving the larger patient double the tidal volume based on their actual weight would dangerously overstretch their lungs. The machine does not know the difference. You have to. So how do you calculate ideal body weight? For males, IBW in kilograms equals 50, plus 2.3 for every inch over 5 feet tall. For females, IBW in kilograms equals 45.5, plus 2.3 for every inch over 5 feet tall. Let's run a quick example. A male patient who is 5 feet 10 inches tall. IBW equals 50 plus 2.3 times 10. That gives us 73 kilograms. Target tidal volume equals 73 times 6, approximately 438 milliliters. You round that to 440 milliliters and set it on the vent. Now, 6 milliliters per kilogram IBW is your lung protective default, especially for ARDS and critically ill patients. In some patients without significant lung disease, you may see tidal volumes set up to 8 milliliters per kilogram IBW. But 6 is your safe starting point until you have a clinical reason to go higher. And even then, you verify with plateau pressure, which we will cover in a few minutes. Now that we understand the size of each breath, let's talk about how often we deliver it. Respiratory rate, abbreviated RR or F, is simply how many breaths the ventilator delivers per minute. Normal respiratory rate in a healthy adult is 12 to 20 breaths per minute. On a ventilator, we typically start in that same range and adjust from there based on what the patient needs. But here is where these two settings stop being independent numbers and start working as a team. tidal volume and respiratory rate multiply together to give us minute ventilation, abbreviated VE. This is the total volume of air moved in and out of the lungs every single minute. The formula is simple, and you need to know it cold. Minute ventilation equals tidal volume times respiratory rate. So if your tidal volume is 440 milliliters and your respiratory rate is 14, your minute ventilation is 440 times 14, approximately 6,160 milliliters per minute, or just over 6 liters per minute. That number is not just math. It is what determines how much CO2 your patient blows off every minute. And when CO2 goes wrong, this formula is where you start troubleshooting. This is the most clinically important concept in this entire video, so let's slow down. Your patient's arterial CO2 level, the PaCO2, should sit between 35 and 45 millimeters of mercury under normal circumstances. When an ABG comes back outside that range, your job as the RT is to adjust minute ventilation to correct it. And this is exactly where that bedside knowledge we talked about in the intro separates the new grad from the clinician. CO2 too high, PaCO2 above 45 millimeters of mercury. Your patient is not blowing off enough CO2. Minute ventilation is too low. You need to increase it, either by raising the respiratory rate, increasing the tidal volume, or both. In practice, adjusting the rate is usually your first and safer move. You already have tidal volume set at a lung protective level, and you do not want to push above that without a compelling clinical reason. Increase the rate first. Recheck the ABG. Reassess. CO2 too low. PaCO2 below 35 millimeters of mercury. Now you have the opposite problem. Your patient is blowing off too much CO2, a state called respiratory alkalosis. And this is not a benign finding. Respiratory alkalosis causes cerebral vasoconstriction, cardiac arrhythmias, and electrolyte shifts that can destabilize your patient. You need to decrease minute ventilation, reduce the respiratory rate, or in some cases, carefully reduce the tidal volume. Here is a rule of thumb worth memorizing. Changing the respiratory rate by 2 breaths per minute will shift the PaCO2 by approximately 2 to 3 millimeters of mercury in the opposite direction. So, if your PaCO2 is 52 and your goal is 40, you need to increase your rate by roughly 4 to 6 breaths per minute. That is the kind of bedside math that becomes second nature with practice, and it will make you look sharp every single time. Before we get to plateau pressure, there is one more concept that will take your understanding from textbook to bedside, and that is dead space. Not all of the air you deliver actually reaches the alveoli where gas exchange happens. Some of it stays in the conducting airways, the trachea, bronchi, and bronchioles, where there are no alveoli and no gas exchange takes place. This is called anatomical dead space, and in a normal adult it is approximately 150 milliliters, roughly 1 milliliter per pound of ideal body weight. So if your tidal volume is 440 milliliters and your dead space is 150 milliliters, only 290 milliliters of that breath is actually reaching the alveoli. That 290 milliliters is your alveolar volume, the fraction of each breath that is actually doing work. This matters clinically for 2 reasons. First, if your tidal volume is set too low, you may not be moving enough air past the dead space to meaningfully ventilate the alveoli at all. Second, and this is the advanced concept, in conditions like ARDS or massive pulmonary embolism, dead space can increase dramatically. Flooded alveoli, collapsed alveoli, and obstructed vasculature all create regions of the lung that are ventilated but not perfused. Air goes in, but no gas exchange happens. This is why some of your sickest patients have sky-high CO2 levels even when their respiratory rate looks adequate on paper. They are moving air, it is just not reaching functional alveoli. Understanding dead space reframes how you look at ventilation entirely. You are not just moving volume. You are trying to get that volume where it needs to go. We have talked about setting tidal volume, but setting it is only half the job. The other half is verifying that the volume you set is not causing harm inside the lungs. That is where plateau pressure comes in. Plateau pressure, abbreviated PPLAT, is measured at the end of inspiration when airflow has completely stopped. It reflects the elastic recoil pressure of the lungs and chest wall, and it is the single best bedside indicator of whether your tidal volume is causing overdistension. The target is 30 centimeters of water or less. If your plateau pressure is above 30, that tidal volume is too large for those lungs, even if it is only 6 milliliters per kilogram IBW, and you need to reduce it. In very sick lungs, particularly in severe ARDS, you may need to drop as low as 4 milliliters per kilogram IBW to keep plateau pressure in a safe range. That is called permissive hypercapnia. You accept a higher CO2 in exchange for protecting the lung. It is a deliberate clinical decision, not a failure. You measure plateau pressure by performing an inspiratory hold on the ventilator, a 0.5 to 1 second pause at end inspiration. Most modern vents make this straightforward. Make it a habit. Every time you set or adjust a tidal volume, check the plateau pressure before you walk away from that bedside. Let's bring it all together. Tidal volume is the size of each breath. Set it at 6 milliliters per kilogram of ideal body weight, calculated from height, not actual weight. Respiratory rate is how many of those breaths we deliver per minute. Multiplied together, they give you minute ventilation, and minute ventilation is what controls CO2. Pack CO2 too high? Increase the rate. Pack CO2 too low? Decrease it. Remember that not all air reaches the alveoli. Dead space is real, and it matters in your sickest patients. And always verify your tidal volume with plateau pressure. Keep it at or below 30 centimeters of water, because the volume that looks safe on paper can still be causing harm inside those lungs. These are not just board exam answers. They are the decisions you will make at 2 in the morning when an ABG comes back wrong and everyone is looking at you. Know them, trust them, apply them. In the next video, we are going deep on FiO2 and PEEP, the two settings that control oxygenation. If you have ever been confused about oxygen percentage versus saturation targets, or why we titrate positive end expiratory pressure the way we do, that video is going to clear it all up. Subscribe so you do not miss it. Thanks for watching Just Breathe RT. I will see you in the next one.